my screen visible?
Yeah.
Yes.
Okay, so to set the ball rolling, I'll start with the migrated herniation. So this is a case of a 65-year-old lady who presented with severe acute onset right leg radicular pain for about 3 weeks that had worsened for the past 1 week. So she was a known case of chronic kidney disease with deranged renal parameters to some extent, multiple comorbidities like diabetes, hypertension, and some heart condition. Her ejection fraction was 30%. The radicular pain was so intense that she wasn't even able to sit, and she was practically on the stretcher, confined to bed. And neurologically, she had a grade 3 quadriceps and grade 2 tibialis anterior on that side. She did have some chronic low-grade back pain for preceding several years. This is her X-rays. And this is her MRI. So I'll just run through the MRI and then we'll take opinion from the house. So we can see there is a significantly up-migrated L3-4 herniation on the right side. It doesn't look like a foraminal type. It's a up-migrated intracanalular herniation at L3-4. So this is the anatomy of the herniation displacing the thecal sac. So what would be the opinion of the panelists here to how to manage about this case? So these are the challenges we have here. She has a CKD, which we do not have a much choice of giving a prolonged conservative treatment in the form of analgesics. The comorbidities also warrant that she should at least become mobile at the earliest possible. But at the same time, they pose significant challenge in terms of surgical treatments if we have to choose one. So, Pramod.
Yeah. Does she have any exiting route symptoms?
No.
Yeah. Okay. So purely traversing nerve root symptoms, L4 nerve root symptoms, isn't it?
Yeah. No. It's a up-migrated one. So she has, it's a L3. She had some L3 root symptoms as well because quadriceps was weak.
So she had both the nerve root symptoms, the L3 yes. and L4 also. Okay. Yeah, it is possible for us to do a transforaminal approach in such cases because up-migrated discs are relatively easy to treat by a transforaminal approach as compared to down-migrated disc herniations because the pedicle doesn't come in between. So we can definitely reach inside the canal also, and it is possible for us to decompress both the traversing and the exiting route at the same time by transforaminal approach.
Sambhav, what is it?
So
do you anticipate any problems in transforaminal approach in this case?
I don't think so. It would be a problem. The only thing is my decision for interlaminar versus transforaminal would mainly depend on what the anesthetist also is comfortable with. If GA is contraindicated in this case, considering the comorbidities or the ejection fraction, then definitely my first line of management would be a transforaminal approach. But if the anesthetist, is the patient obese, or there are some contraindications with regards to prone procedure under LA also, and if GA is preferred over a LA, then definitely I would do this interlaminar. So my decision would definitely be based on what is safer for the patient with regards to anesthesia point of view. But this could be tackled from both the sides, transforaminal as well as interlaminar.
Professor Wojciechowski, is he with us?
Yeah. I think it's also both is possible. You can go from transforaminal and also from interlaminar. In my opinion, maybe from interlaminar it's a little bit easier because you are really don't need to go through the foramen, so it depends on the size of the foramen. But we have a big foramen, so in this upper lumbar spine usually we have big foramens, so it's also not so difficult to go through the foramen. But it's also possible to go interlaminar. So both is possible. So I think it depends on your experience. When you are good experience with the transforaminal, so the advantage of the transforaminal approach is that you need less bone resection. So then you can do a transforaminal. Some people are not so experienced with the transforaminal, so they prefer the interlaminar. So you can also do it interlaminar.
Any other panelists would like to throw any different point of view from the one which we have already discussed? Dr. Ali, anything more than what we have discussed?
Dr. Ali is not there.
Okay, so if there's none, I'll just share what I thought, what was the thought behind choosing what we treat. See, she's multiple comorbid conditions, and as Sambhav rightly pointed out, the anesthetists were definitely edgy about giving general anesthesia to such a patient. And but my concern with transforaminal approach was that many times I find that these herniations are multi-fragmented. And in transforaminal approach, sometimes you can miss multi-fragmented herniation because you think sometimes you have removed one or two fragments, and that becomes the end of your procedure. Anyhow, because of the comorbid conditions, because of it's a up-migrated herniation, and we had a reasonable experience of treating such cases with the transforaminal. We chose the transforaminal approach, and I'll just show you. But we agree that no one has chosen nerve root block, and it's only a surgery, which is again dependent on whether you're going to do a microscopic or endoscopic, and the panel agrees that it is an endoscopically treated surgery. Anesthesia we already discussed. So we chose the transforaminal approach under local anesthesia. In this case, the only thing is that our trajectory has to be slightly caudal to cranial because we are going to advance our cannula superiorly through the foramen. And as shown here, we kept the cannula just in the foramen. We did not dock in the disc space. And once we keep the cannula, and you can see on the picture on the right, there is a significant angulation permitted from the initial horizontal trajectory to distal to proximal trajectory. This is a small video that shows how it is done. So we, as you see, we are just inside the foramen so that we are able to see the posterior longitudinal ligament. This is the exiting nerve root. And on the top, you can see the ligamentum flavum under the facet, and you can see the herniation. Now you see one fragment that is coming out. And as was my apprehension, it is multi-fragmented. So we have to ensure that we do not miss out on any fragment because it's a neurological deficit and she is not mobile because of the deficit. So we have to ensure that we don't miss out on any fragment. And once we do multi-fragmented, and then you see the exiting root is already decompressed, and you can see the traversing nerve root at the end of the procedure. So that is how we were able to get a reasonably good outcome. And this is the post-operative MRI. Any comment?
Very well done, Arun. I think there is no doubt about what you have done. It's well done.
Absolutely.
Sambhav?
This was a perfect indication for this. But as you rightly said, one worry is always that have we left any fragments behind? So obviously, if this lady was a younger patient with no comorbidities, I would probably venture into interlaminar where I see the whole nerve right from the shoulder to the axilla. But what you've done is the perfect indication, and it's very well executed.
So my point is that even if we are anticipating multi-fragmented herniation, one should aim to look for the reasonable length of the nerve roots, both the exiting and the traversing, so that there's no doubt. And that is what is the ultimate aim of the procedure. So shall I move to the second case?
Sure.
Yeah, please. Yeah.
Now, this one is the opposite of what we just saw. This is a 70-year-old male with a left leg radicular pain and presented with weakness and inability to walk. His left iliopsoas and quadriceps were grade 3. He had a sensory hyposthesia below L2 dermatome on the left side and hyporeflexia, but he was voiding by self. This is his MRI that shows a large L1-2 disc herniation here. You can see this is a large down migrated L1-2 herniation, which is going right up to the lower pedicle of the L2 vertebra. And these are the axial sections showing a disc which is going right up to the lower border of the L2 pedicle here. Now, what do we think about it?
So in my opinion, probably L1-2, I would, with a down migrated disc, I would prefer the interlaminar approach rather than the transforaminal.
Right. That's correct. And Ajay is here. Ajay Krishnan.
Ajay probably is not there.
And
Yes, sir.
I would agree. I will also do the interlaminar approach. I think L1-2, it's difficult transforaminal because you need to respect the kidneys, so you have the posterolateral approach. So you would need to resect some parts of the pedicle just to go down. When it is a multi-part sequestered disc herniation, so I think the interlaminar approach is fast and easy, and it's the best decision for this patient.
Pramod, anything from your side?
Yeah, I have a slightly different opinion. I think both the approaches are possible, but the amount of bone resection which you do at L1-2 level to reach the lateral border of the dura or the lateral border of the nerve root is quite significant. And secondly, I'm worried about the possibility of the neural retraction by the interlaminar approach. So if you really want to see the fragment completely, you do have to retract it, and that may add on to the insult which is already there. She has a grade 3 power. One of the advantages of transforaminal approach in such cases is the foramen is very big. Secondly, the mediolateral thickness of the pedicle is very narrow. They are narrow and vertically elongated pedicles.
Right.
So it's easy to get for us to get under the pedicle. Okay, the facet is not large. So because the facet is not large, you do not take a lateral approach. You can just go in through the posterolateral approach, and I think it's possible to do it with a transforaminal approach by a surgeon who has some experience, definitely.
Okay.
I completely agree. There's only one thing that if you see, if this disc was more of a very central disc,
right,
I would definitely even prefer probably a transforaminal. But it was like a paracentral disc. It's more towards the left side, and that's what I think probably makes it easier then to try and grab that fragment out from the interlaminar approach.
No, the problem here is that it is a significantly down migrated herniation, and the transforaminal approach will definitely have a problem of removing the down migrated fragment, especially because again it is a 70 years old male with the possibility of multi-fragmented herniation. So you may be able to get one or two fragments, but you may still miss something which is very close to the nerve root in the pedicular zone.
Arun, we are running out of time.
I'll just run through. I thought what Pramod said. So actually, I agreed that we will need to cut a lot of bone in the interlaminar approach. So I used the transforaminal approach, and the angulation was downwards. So of course, we had to drill a little bit of the pedicle. This is a small 1-minute video I'll run through. So this is the orientation. 12 o'clock is dorsal and 3 o'clock is caudal. So this is the facet and the undersurface of the facet which we are drilling. Along with that, we will be drilling the upper surface of the pedicle. So we feel the medial border of the pedicle here, and we drill the tip control burr as well with the matchstick burr. Both we combine. And now we're drilling the medial border of the facet pedicle junction. And now we can see the nerve root, and then there is a fragment right across, so which we mobilize with this hook. And then we remove the fragment. And because now we have done a little bit of foraminal widening, we feel confident that we can remove multiple fragments. So like we removed only one, then we remove another one here. And then we look distally towards the lower part of the pedicle here, and then we can remove that as well. So at the end, we get this nicely decompressed nerve root right from disc to the pedicle ending. And this is his post-operative MRI showing this much is the amount of pedicle which we had to drill, superior border of the pedicle.